Well, good evening, ladies and gentlemen. And it's a pleasure to welcome you to this session on clinical translation of flash therapy. And we have the privilege today to have a highly distinguished speaker, a guest for this session, and Professor Metz, who is chairman of radiation oncology at the prestigious University of Pennsylvania. And Professor Metz will share with us the short and midterm perspectives for flash clinical translation. Thank you.
Thank you, and thank you so much for inviting me for this talk today. And I'm going to try to build upon what Damian Weber talked about this morning and really talking about preclinical protons. And I'm going to try to project, which is always fraught with problems, project to the future of where we can go with clinical trials. So I'll be a little bit provocative during this session today as we go through this. I don't have any disclosures to report. So I know everybody knows this, but I want to use this slide for a reason. This is a depth dose curve that looks at protons versus photons, and we see the Bragg peak in red there. And I use this to remind us that we're using the Bragg peak today daily in clinical operations when we do pencil beam scanning for patients. That's not what we're doing with flash most of the time in research. Most of the time, we're not using the Bragg peak, we're using that entrance dose, that plateau area, we're shooting through, all the way through. And that's the data that we're using that we're going to go through a little bit today. Now, the important news about that is that's fairly dirty, right? That's a worst case scenario for what we're seeing because we're not optimally using the beam right now in regards to sparing other normal tissue. So there's opportunities potentially if we can harness flash with conformal dose down the road. So why proton flash? Well, you've heard some of this already, but there are challenges out there with using photons. There aren't machines available. There's great work being done by Billy Liu and his team with developing the phaser system, but that's years away. Same with electrons. It's great for superficial treatments, but when you go to deep-seated tumors, you start to have issues with exposing normal tissue to radiation dose. Whereas protons, today's accelerators can do it today, and almost all the vendors now can do it in the clinics today with some modification of their current systems. And we've seen that with these systems, we have sparing of normal tissue consistently, but importantly, the same effect on tumor as normal or conventional dose radiation has. And that's been shown in multiple places, and we've seen that today. And there is some potential to combine the flash effect with the Bragg peak effect going forward. So coming back to what we're doing today, this is just a cartoon, obviously, but if I have a patient, we're dividing this tumor up voxel by voxel into 5 millimeter squared cubes and treating this with a beam that's perfectly conformal to the dose, particularly on the distal side of the treatment, with no dose going beyond the target itself in the treatments today, and less in front of the target where we can conform better compared to where we were with double scattered treatments before. And almost everyone is using pencil beam scanning. There's opportunities to think about this for the future going forward with clinical trials in regards to harnessing this technology. Just to step back a moment for where we're at the University of Pennsylvania, we started this process about 4.5 years ago at getting involved with flash. And Alejandro has talked about how important dosimetry in physics is with flash. And I'll come back to that in a minute and give you an example of how important that is. We went into biologic validation in mice and cells, trying to identify what is the mechanism of action. And you've heard some hints of that. We're leading something going on in the stem cell compartment, in the stem cells or the microenvironment itself. And then we moved into canine models back in 2019, which I'll go through in a few moments. And we hope to go into human clinical trials next year. I mentioned accurate dosimetry and accurate physics. And why do I say that? When we first did our experiments in flash and we saw the flash effect, we were very excited. And the next thing Costas told me is we need to do this again. So we went and did it again, and we didn't get it. And we didn't know why. Well, we were treating with protons clinically every day, our patients, and everything was going fine. And then we started to see deterioration of the beam. And it turns out there was some deterioration in the RF prior to issues with the beam coming out of the cyclotron that we could see in patients on a daily basis. But it turns out there's small perturbations in the RF were affecting the flash dose. We could hit the dose, but it wasn't the same packet of dose that we gave to the patient, the animal each day. So we lost the effect. So that tying of the technology to the biology is incredibly important, and understanding the physics and dosimetry is incredibly important for it to be reproducible. I'm just going to glance over this because Damien went over this earlier, and Yannis did much of this work and looked at whole abdominal radiation therapy. And the important thing I want to pull out of this is we were trying to get to the LD50 in mice. And we got to that with standard dose radiation, and there's about a 30 to 40% benefit in FLASH in survival. And that 30 to 40% kind of holds up across multiple studies in the impact or window that we're seeing. Now I say window because you can overwhelm the FLASH dose. Or the FLASH effect by giving too much dose. So we go up to 18 gray here, all the animals died. So you lose the FLASH effect. So we have to define what is the FLASH effect in every disease site or every normal tissue of the body going forward, because they are different, which complicates all of this. And we saw that it's equipotent in regards to tumor control, which is incredibly important, and we've shown this in multiple tumors, as other groups have. This just shows some of what we saw in the intestinal fibrosis. In the top panels, I don't know if you can see this pointer, in the top panels, this is normal intestine. The middle is standard dose rate, and you can see this blue fibrosis and almost complete loss of the villi, which absorbs the nutrients and fluid in the abdominal, in the intestines. Whereas down here, this is the FLASH dose rate. You see some fibrosis, not nearly like you see in normal tissues, but importantly, complete preservation of the villi. And that's where you see the absorption of nutrients, which is incredibly important for the patients moving forward. We also saw this with skin, with lymph nodes, with reduced lymphedema. We've gone to multiple areas and seen this FLASH effect. Again, trying to get to the LD50, you see about this 30 to 40% difference in outcome between FLASH and standard radiation, again, with a window. Importantly, in this sarcoma model, same exact effect on the tumor itself with standard radiation and FLASH. So I've been a big proponent early on that we need to do large animal studies. And why have I been a proponent for that? I really believe we need to work out the feasibility for more complicated disease sites. I think the trial we heard about earlier, the FAST-01 trial, is a great trial looking at peripheral extremities, but it becomes different when you're looking at internal organs and risks with that. And I think we need to understand when we're dealing with complicated diseases what's happening to the other tissues. We want to help elucidate what are the real mechanisms of FLASH effect. We're hearing hints of that, but nobody has it all nailed down completely. We also need to define the safety in humans. And for us in the US with the Food and Drug Administration, it's critical we collect safety data in animals to really move forward. I also believe we need to do end-to-end testing in non-clinical human models going forward. And also, let's be frank, we're going to make some mistakes, and I'd rather do that in some animals before we do it in humans. And I'm going to give you one example of that. And this is exactly what the FDA is concerned about, for instance, in the US. We've been treating with FLASH, we've been treating dogs for a while. We had one time we were treating a dog, and we were setting up, and these take a long time to set up these dogs. It takes a couple of hours sometimes with the anesthesia and everything we need to do. Everything was being done manually with the IBA system. We had a great system in place, but it turns out we had written a prescription for the FLASH dose. The dog got standard dose. That's not supposed to happen, right? But that's the kind of thing the FDA is worried about, that we deliver FLASH in standard mode or standard in FLASH mode, right? So it was a manual system. We've come up with new checks and balances. One of our issues was we learned that when we set the system up, after a couple hours, it times out and reverts back to the original system. We didn't know that until we made that mistake. We won't again, but these are the kind of things you learn going through these studies and treating the animals moving forward. So we've had this large osteosarcoma study that Keith Sengels has led at Penn. It's been really critical in a learning experience. So we treated 29 dogs with osteosarcoma. These are patients' pets. We didn't give dogs cancer. They developed these cancers naturally. We treated them with standard dose rate protons or FLASH-based proton radiation. We treated both the tumor and normal tissue because it turns out these dogs, the standard of care is amputation for the dogs. So we treated them 5 days before amputation. So we get tumor information, but also normal tissue information in the bone, in the skin, in the muscle, to really look at the effects of these and do RNA sequencing analysis and immunohistochemistry and all kinds of other analyses moving forward. That trial is completed, and there's some great data coming out that's going to be published and looking at different activations, different gene expression. So I'm very excited about the data that our team's going to be putting out there. We are moving forward down the road with an additional trial. As I said, we amputated the dog's legs originally. The next trial with dogs in regards to osteosarcoma, our plan is to do a dose escalation study and not do amputation. Can we actually preserve the dog's leg and not amputate them? So that'll be the next phase 1, phase 2 trial going forward. I'm going to speak about the head and neck trial in just a couple minutes. So this is just an image of the dog on the table. These are complicated. They're under anesthesia, obviously. This is the beam coming out this way with the aperture. It's coming out of the wall over here. This is, as I said, we go through a normal tissue shot, and we go through a shot of treating the tumor itself. I mentioned earlier about conformal flash, and where should we, why are we thinking about this? Well, we've been doing shoot-through almost all the way through. We've started doing conformal flash for some cases, but mainly we've been doing shoot-through thus far. It's simpler to do shoot-through, no doubt about it, from a planning perspective and the shoot all the way through. We can do it easier. The problem is it does irradiate the entire track. So you're losing that benefit of using the Bragg peak by irradiating the entire track. We may need to have more beams to actually effectively treat this down the road. With Bragg peak flash, we think we'll be able to reduce that by using this Bragg peak itself and not have any dose beyond the target itself. We think that will enhance the effect we're seeing with toxicity when we're treating patients down the road. It's going to be more complex in regards to planning, and we've partnered with Research and IBA to develop the planning for this, and hopefully we'll be able to come up with the right approach down the road. So we're moving into this animal trial now, which has already started, and Keith Sengel is leading this also. It's a dose escalation trial, a 3x3 design. These are dogs with naturally occurring, so people's pets, that develop cancers in the head and neck region, which, you believe it or not, are relatively common in dogs. And we have the vet school right on campus at Penn, so we're very fortunate. So we have a fair number of these dogs coming through that we can actually treat. It's open to any dogs that have biopsy-confirmed non-metastatic cancers of the head and neck region. We're treating with PBS flash protons, either through a shoot-through technique or using a ridge filter. We're using a spread-out Bragg peak, so to the width of what we want to treat in that animal itself. We're looking at normal tissue toxicity, tumor response, and we're also looking at delayed toxicity over 1.5 years and tumor response over that time. The dose levels are 8 gray shoot-through versus 8 gray with a spread-up Bragg peak versus a dose escalation to 12 gray spread-up Bragg peak. There's 2 treatments themselves, so 2 fractions, spread out by 4 to 7 days going forward. This study has just started. We've treated 2 dogs so far. So we're starting to move along with this, but I think will give us important information because we do believe head and neck cancer, which is a very toxic treatment in today's world, is something that may benefit from flash radiation. I'm just going to mention this quickly. We heard about the FAST-01 trial from Damien. We're going to hear more details tomorrow, but it's a really important trial in that it showed the feasibility of delivering flash in these patients, and we're benefiting from the work that was done there. But also, I'm going to remind you, it was a shoot-through technique trial. So this was not a conformal trial, but shoot-through. So I'm going to change gears a little bit and be the provocative side on where we should think about going with clinical trials moving forward. And some will say, Jim, you're crazy. Pediatrics, really? But let me talk to you a little bit about why we should be thinking about pediatrics. We already know pediatric patients will probably benefit most from proton therapy out of any group of patients we treat because of the reduced toxicity and reduced normal tissue treatment. That's all related to the dosimetry, right? That's all the physical aspects of the beam because it stops. So in this craniospinal radiation, what you see with conventional dose rate compared to proton-based radiation is significant reduction of normal tissue being treated. But we're still treating a lot of normal tissue. We're still treating brain, spinal cord, spine itself, which gets impacted by a number of things. In fact, when you look at pediatrics, tissues in pediatric tumors are even more sensitive, much more sensitive than adults. So skeletal growth, neuroendocrine disruption, endocrine disruption, normal organ damage, and all those organs you see listed there, vascular damage, and also secondary malignant neoplasms are all issues in pediatrics that we face today, still with protons. It's reduced with protons, but it doesn't go away with protons. And children who survive these cancers, we're talking about decades of living with these toxicities that rear their heads in the future. So protons may offer a benefit already, but may offer more with Flash going forward. Also, we have to recognize the logistics of treating patients with protons. Pediatric patients are complicated. It's usually given with systemic concurrent chemotherapy. Many of these patients need daily anesthesia, as much as 2 hours a day for up to 6 weeks. At our center, we treat between 7 and 15 patients on general anesthesia per day. It is really time-consuming for these patients. And the older children even need significant training from child life specialists from coming in every day. And it's disruptive to school, work, other things of patients coming in for these. So protons may even exacerbate stuff because of the length of treatment overall. So the question is, can Flash protons actually give us benefits with pediatrics and protons going along by magnifying, increasing that normal tissue sparing in some ways? And we think it actually can with kids. And there's some early data that's out there, and most of the work is in electrons, and from the team at Lausanne has done great work looking at CNS tumors. This is from GBM Model, looking at issues in regards to discrimination index scores, and looking at can they, at time out, do better in regards to memory, and they actually can in neural function. In fact, there's been additional doses, I'll go to the lower one, with neuroprotection in juvenile mice with ultra-high dose radiation. And when you look out at 4 months, you see almost similar results from the control from the Flash groups. And this is very early data, so I'm not jumping right to patients. But I will tell you, at CHOP, at CHOP, Children's Hospital of Philadelphia, we have a very large pediatric population that we treat. We've started animal studies for medulloblastoma and also neuroblastoma, which are real problems in children. And we think, and if those work out, we do plan to go to human studies in kids down the road. It won't be the first thing we treat, but we actually believe that they will be early on in our treatment course. The other one we're very concerned about is pontine gliomas, which have horrible outcomes with conventional radiation today, and maybe something that we move towards. Now, we know the FDA is very concerned about treatment in pediatrics in the US, and we'll have to do these animal models first to show it, which I think is incredibly important, but it's on our radar screen for clinical trials down the road. So to be a little bit more provocative, what about benign diseases? And you might say, why would we go there? Well, this reduced toxicity may open opportunities for benign diseases that we pushed aside in the past and said radiation was just too toxic. We have the potential to reduce second malignancies, which has been a real issue with treatment of benign diseases in the past. Depending on the impact of normal tissues, that will define the targets that we would utilize. We certainly need to understand the mechanistic studies for these areas. But I want to remind you that although there's diseases that are, quote, benign, that does not mean they're not, although they're not cancerous, they may still be malignant for the patient. So let me give you an example here. So we're doing a lot of work with Keith Sengel, who's leading this team, for SBRT, for cardiomyopathy-related ventricular tachycardia. Ventricular tachycardia, these are patients that are basically drugs are not working anymore. They're reliant on having an AICD implanted in the heart, and they get shocked every time they get ventricular tachycardia. These patients are getting shocked many times a day, even, and the patients will describe this as getting hit by a Mack truck each time it goes off, and they dread it every time. So from a quality of life perspective, it's actually pretty horrible. This actually came from the clinic, so we started treating these patients initially, and now we're taking it back into the lab to understand the biology. So we've actually treated 29 patients to date with this, and fortunately it was our cardiology group that was driving us with this and came to us with this, and we got involved with it. And what we've seen is preserved ejection fraction, we've reduced their amiodarone, the drug they need to maintain their rhythm. And also, the ventricular episodes, ventricular tachycardia, have reduced significantly. So this looks at pre-treatment in these patients. You can see an average are up around 40 of these, some up in the hundreds of pre-treatment shocks in these patients in the period before they were initially treated. It drops down at 0 to 6 weeks, it drops down significantly and continues to drop down over a year. This graph actually shows what these are the first 12 patients, what they were experiencing prior and what they saw after this treatment. And what's amazing is this treatment was always thought to be due to causing fibrosis and disrupting the pathways of the electrical transmission in the heart. Well, we see this effect within days, and fibrosis doesn't happen for months. So it's not fibrosis. We don't understand the mechanism of action. There's something physiologically going on. So we've taken this other way back into the lab and are figuring this out. And Keith has actually started doing work with Giannis in mice and looking at flash, proton, SBRT in the hearts in mice, because we're looking this way. Because it turns out, as I show you in a second here, conventional photon SBRT has spread out a significant amount of dose. And remember, these patients have horrible cardiac function. And this dose is actually really important. It actually really affects these patients and how they do long term, whereas protons can significantly reduce that. Now going to flash, if we can reduce that toxicity even more, it's potentially very important for these patients. In fact, Keith sent me the slide last night, and this looks at flash proton and looks at signaling of tumor necrosis factor and also TGF-beta. And what you can see is reduced, particularly in the TGF-beta, which is almost normal in regards to the impact of seeing that stimulated with flash-based radiation in the heart. And these are the graphs showing no radiation, standard radiation, and flash. So there is an impact here. So we're very excited where this may go down the road in the future. So we've treated 29 patients to date, not with flash, but with SBRT, and it's been tolerated really well is the bottom line. But these are patients that have very advanced disease, and we're going to start taking this into earlier disease, potentially. That fibrosis is incredibly important for the long-term longevity of these individuals. So that's why it's so important to elucidate this flash effect and potentially help these patients live longer down the road. So some further thoughts on clinical targets. So I really believe we should be considering normal tissues that have significant early toxicity from radiation. Those things that come to mind: lung, liver, head and neck, GI tumors. And I'm saying normal tissue toxicity first because I don't necessarily want to define the tumor type. I want to define first the region of the body, because that's the way I think we have to think about flash going forward. Thinking of tumors themselves, where do we get information on early control? Well, lung, liver, head and neck tumors, pancreas, sarcomas. We all know pretty early whether or not those are progressing or not, so we can get early data on that. And also to try to get surgical data, think about some tumors where radiation is used in the neoadjuvant setting. So sarcomas, pancreas, esophagus, rectal cancers. But I also think we need to avoid tumors that we could experience a catastrophic event or make a mistake initially. So I think we need to be really careful with the brain, the spinal cord, and pediatrics in the definitive setting. I think pediatrics in the metastatic setting or the very advanced setting is a different story, but in the early setting we need to be very careful. So where are we thinking of going? So we think our first clinical trials will be, obviously we're doing the preclinical work in head and neck cancers and sarcoma in some of these settings above. And when I say settings, those locations, those areas of the bodies are where we're thinking about. So specific plans for us going forward. So we've installed the flash kit from IBA. We've been doing all the work you saw earlier was in our research room. This work we're now doing in the gantry itself, so we are treating with flash in the gantry room with PBS. We're working with IBA to obtain the IDE from the Food and Drug Administration. That's taking some work, but we expect to get that soon. We are going to be, over this next number of months, defining the technical parameters and performing clinical trials in large animals to see where can we take this in humans most effectively going forward. And we expect to start human clinical trials in the next year moving forward. So we heard a little bit earlier about questions that still need to be answered about flash, but I'll talk a little bit about these. One, we are still trying to find the biologic mechanism, obviously, or mechanisms. I should have, as I have an S on that, I should say. There's a lot of theories, early indications, but there's still a lot to learn. We heard earlier, Karen brought this up with Damien, is shoot-through or conformal flash the appropriate delivery mechanism? We don't know. We don't know, and that's something that we need to investigate. I think dose and fractionation, we probably have to completely rethink this, and as we talked about earlier in Damien's talk, dose rate, and what does that mean for normal tissues versus the tumor itself? Should we look at single fraction or fractionated flash? Flash alone or conventional with a flash boost? Single course flash or similar to pulsar with intermittent delivery in some ways? And what are the multiple field effects on flash going forward? And should we even do flash with grid therapy, which we've used in the past but may come back in some ways? Importantly, and nobody's really done any of this yet, what are really the synergies with chemotherapy and immunotherapy of Flash? Only very early work's been done, but we'll see in animals going forward. And what are those differential effects on normal tissues? Our treatment planning may be extraordinarily different down the road if we understand the different sensitivities of normal tissue or impacts of Flash on normal tissues in the future. And obviously, many, many more. I'm sure every time one question gets answered, we have 5 more questions that come up with this. So one word of caution about going too fast in Flash. I think this was an important paper by Jeff Buxbaum and the team at the NCI of really being methodical and scientific in Flash when we bring this to the clinic and really doing effective clinical trials. I can say this because I'm a Penn. We blew it in regards to gene therapy. So we had a patient who we treated with gene therapy who wasn't in a situation where they were going to die from their disease. We didn't understand the viral mechanism, and that patient died. And it put gene therapy back a decade. So we need to be very careful that we don't make the same mistakes with Flash and put the field back a decade. And we really work together to ensure we do this in a safe and appropriate way. So in summary, I think Flash absolutely has the opportunity to change the paradigms of what we do and upend a lot of our assumptions in radiobiology and what we've learned through over the years. However, I think we need to systematically evaluate Flash and look at the potential through science, define the mechanism of action in small animals, and as we're taking it to larger animals first before human studies with protons. But I think cooperation with clinical trials across everyone in this room is going to be critical to really see the potential for Flash moving forward. I think there's going to be a lot of challenges, technical, biological, financial. This is going to cost money to do, no doubt about it. But I think with cooperation, we can overcome these in the future. So I want to acknowledge my team who's really done all this work and our collaborators. I just get to stand up here and be the megaphone, but they really do all the work with this. So thank you so much.
Well, great, thank you. Maybe we have time for a few questions. Do we have questions online?
Nope.
Okay.
Jim, thank you very much. It's excellent. I have a question, but mainly a concern when you mention pediatrics. Mm-hmm. I'm really afraid about that. Flash is not only dose rate, but you need also a threshold in the dose. So if you push to make hypofractionation to get higher dose, believing that Flash would compensate, I'm really worried. So unless Marie-Catherine will show us in a few minutes or tomorrow that we have Flash with 1 gray 0.6, if that is not the case, I'm really worried.
Yeah, no, I think it's an appropriate concern, Alejandro, and I'm being provocative on purpose with this. I do believe in, this is why we're going with animal and small and large animals first before going to pediatrics. I think that's going to be absolutely critical to define exactly what you just said. We don't know. There is a lot of excitement on the pediatric side with our team at CHOP on this, which is great to see. But we have to be cautious. We have to do this the right way, which we will. But I think there may be some opportunities here. If we can harness the Bragg peak, that we're sparing those normal tissues, I think that's going to be critical for pediatrics, to harness the Bragg peak. I think the shoot-through, I think, would be a real problem in the pediatric setting as opposed to the Bragg peak setting.
I think we can have time for one more question.
Some really interesting ideas there, Jim. When you talk about benign disease, every time we see a slide of a normal tissue effect, we have to also show the tumor isn't affected. How do you know when you're treating benign disease in, say, the heart, that you're actually not going to spare the effect that you want to achieve through Flash, with Flash?
So I missed the end of that. I'm sorry, what was it?
How do you know if you're treating benign disease in the heart? How do you know you're not going to spare with Flash the effect you're trying to induce in your tissue?
It's a great question, and this is why the mechanism is so important. I think each of those, and I was kind of hinting at the benign disease area, we have to understand the mechanism of what is behind that benign disease. Because you're right, you could actually spare that benign disease with Flash itself, and that's why these animal studies are so important. But good news is, with the early data, very early data, we're seeing SBRT for ventricular tachycardia. That's not what we're seeing. We're not sparing what we see of the disease itself, but we are sparing the fibrosis and things. very early. But I think it's important to go disease by disease and not just say, we're going to treat benign disease with flash radiation. You have to understand what's the mechanism behind that disease itself.
Maybe a very short question. You mentioned that you are going to start a clinical trial in 24 or very soon. And what are your plans there? Are you going to use the PBS, the rich filter, or the shoot-through?
Well, that's exactly what we're evaluating now. Why we're doing this trial in dogs that actually looks at spread-up Bragg peak versus ridge filter and using with the ridge filter versus shoot-through. I'm hoping that we're going to be able to do the ridge filter and treat with the spread-up Bragg peak, but I don't know that yet, and that's why we're doing the clinical trial in the dogs first. But that's ultimately where we want to get to. But this large animal experiment actually impacts the design of the clinical trial and really important for us to do first, so we're learning a lot from that.
Okay, so I think for the interest of time, we need to close the session. So thank you very much again. And